Hi, my name is James Glasbey, and I'm an NIHR and RCS-supported doctoral research fellow in global surgery. Today I'm going to be talking to you about COVIDSurg-Cancer, which is our international collaborative effort to improve data-driven decision-making and support safe surgery during the SARS CoV-2 pandemic. We've been very grateful for the RCS support of this network as part of the COVID-19 research group. It's a hugely impressive research group that has got a footprint all across surgery and oncology. So I highly encourage you to check that out. Personally, I've been supported by an RCS fellowship, which I'm told was from people running the marathon and half marathon to raise funds for the college. So a huge thanks to them. And I hope I've paid things back at the end of this process. And today I'm going to talk to you about the pipeline that we've developed as a collaborative to get data out to the world and hopefully influence policy and practice during the pandemic. So COVIDSurg is our international network, and it's grown from the back of GlobalSurg at the NIHR unit on global surgery, with investigators across 116 countries and a mailing list of about 35,000 investigators. So we think it's probably the largest scientific collaboration in the world. We started our journey, and the first sort of step of our pipeline was in exploring the disease phenotype of perioperative SARS CoV-2 infection. And in our analysis published in The Lancet early in 2020, we showed that infection in the perioperative setting had severe consequences, with 1 in 4 patients sadly dying after surgery and 1 in 2 patients suffering a severe pulmonary complication. So the efforts that we've made since then have been trying to improve safety in that perioperative setting and to try and create the evidence base to do so. And the first example of that was a paper published in the COVIDSurg-Cancer study, which was published in the Journal of Clinical Oncology. And this looked at those COVID-19 free surgical pathways, or you may have heard of them as light or green hospitals or surgical sites, and the effectiveness in reducing infection, chest complications, and death. And we showed that after adjusting for patient and disease and operation-specific factors, these sites really did work. And hopefully, this has given people the evidence to set up the pathways in their hospital. And certainly, we've seen a large increase in this being applied around the world since then. The second question was around routine perioperative testing for SARS CoV-2. And in this early part of the study, that was only being done in around 25% of patients. And what we showed here is that a single swab test done before major surgery or in a high SARS CoV-2 risk area would reduce the rate of pulmonary complications with an odds ratio of 0.68. So again, a simple thing that could be done before surgery, and we've seen a high uptick in this over time. Another question with important clinical relevance was patients that were infected, particularly those with cancer, how long should we delay surgery for? And this is always a risk-benefit decision, particularly with patients with time-critical disease such as cancer. But what we showed in our more recent study, the GlobalSurg COVIDSurg Week, is that after 7 weeks, the patient's risk basically returns to baseline after SARS-CoV-2 infection, unless they're continuing to be symptomatic, in which case the operation should be delayed further. Preoperative isolation is another important consideration. With a strong patient focus, these things can be crippling financially, having an extra 2 weeks out of work, and also there's a risk of social isolation during that time. And in our analysis of the GlobalSurg COVIDSurg Week data, we showed that preoperative isolation overall was actually associated with a higher risk of pulmonary complications rather than a reduction in pulmonary complications. And we hypothesized this may have been due to patients not sticking to their kind of prehabilitation, being less likely to exercise and being stuck at home rather than going about their normal activities and mediating their risk of pulmonary complications in that way. Now, one final question I want to show you today is around COVID-19 lockdowns, which have been imposed around the world. And we showed in the most recent analysis of our COVIDSurg-Cancer data, which has been accepted for publication in the Lancet Oncology, that full COVID-19 lockdowns actually meant that 1 in 7 patients didn't undergo their planned curative cancer surgery. In moderate lockdowns or regional lockdowns, this was about 1 in 20 patients, in comparison to normal circumstances or light restrictions, where it was 1 in 200 patients. So an important effect here. We also saw that low and middle income countries were exquisitely fragile, with 1 in 4 patients in low and middle income countries not undergoing surgery. And we're now working with policymakers to try and improve the resilience of elective surgery in different countries around the world. What impact has this work made? Well, it's actually made a bit of a media splash, and we've been featured in most of the major newspapers, including the Times of India, The Economist, Forbes magazine, and the outmetric impact factor of these papers has often been some of the highest seen in surgery. So people hopefully are reading this and it's making an impact on practice and policy. We're delighted to announce that our collaboration has actually won a Guinness World Record for being the largest collaborating scientific group in the world on a peer-reviewed paper, with 15,000 co-authors on our latest paper. And we're very proud to have worked with patients from Bowel Research UK to create patient-facing resources which have been published in the BMJ and are freely available online, which have now been downloaded more than 40,000 times in 12 major languages for use for patients around the world. We're also working to find ways for surgeons to understand the data and to receive the data in different ways, and we've created a nicely produced policy booklet that can be provided to local hospitals and policymakers. And each paper now has a module available at this website, Surgery 2025, where surgeons can receive CPD for running through some key information about the study. So huge thanks to the Royal College of Surgeons for their support in this work and the COVID research group. And I'm happy, or wasn't so happy at the time, to say that I myself ran the college half marathon to return the favour. And this is an amazing network, an amazing group, and very many thanks for the support of all of our collaborators and funders. My email's here if anyone's interested in talking, and always happy to collaborate. Many thanks again.